Mustafa Sabah, and we'll have a lot of their experience right now. We'll start our panel with a common quote I always use: there is no right and wrong. The hardest decision is in life are not between good and bad, or right and wrong, but between two goods and two rights. Okay, we'll start with one issue now. The debate is when tissue is an issue. If you are going to do refractive surgery, what's the most important parameters when dealing with pachymetry? Is it the preoperative corneal thickness? Should be more than 500 microns, a golden number we always use. Residual stromal bed should be between 250 or 300 microns. Residual stromal bed, of course, is calculated is the difference between the corneal thickness minus the flap thickness and the ablation depth. Some this should not exceed 50%, the nominal residual stromal bed. Marconi Santiago and his colleagues postulated that the PTA, or the percentage of tissue altered, shouldn't exceed 40%, which is the flap thickness plus ablation depth divided by the corneal thickness. And the last one is the biomechanics. Let's start with Professor Mazen Singab. What do you think about the pachymetry when you're assessing a case going for refractive surgery? Which is the most important item you look at? The initial pachymetry, the residual stromal bed calculated, the PTA, the biomechanics?
Very good. I believe in God and PTA.
PTA. So you don't look at the initial pachymetry?
Yeah, of course I look. For example, if I want to do LASIK, it should be more than 500.
So you respect the 500 rule?
Limit. Yes.
Okay.
Yeah. And I don't look for the residual stromal bed because when you consider the PTA, for sure the residual stromal bed will be more than even 300 in most cases. Biomechanics, if I'm lucky, I will have the biomechanics in my clinic, but still till now, no. So I consider the pre-op, I consider the PTA.
Okay. Dr. Hosni, do you agree with Dr. Mazen in this condition?
I totally agree, but I think these are all like elements of, or components of a recipe. Sometimes each one of them is much more important than the other. It all depends upon the type of the patient, the amount of refractive error that I'm going to treat, if it is myopia or hypermetropia, if I'm going to have...
We are talking here about myopia because when tissue is an issue, usually it's myopia, it's not an hyperopia.
Yeah, but I mean, for example, if I have a patient like 490 microns, central pachymetry at this point, and everything is absolutely fantastic, and the cornea is superb, and I'm going to do a correction for a minus 1.5, I'll go ahead and do a femtolasic. I will not stop because it's 490. So, but again, if I mean, I look at the same parameters but differently according to each patient.
So the PTA is the most important.
Yes, PTA. If you respect the PTA, you're home and dry. Everything will fall into place.
Okay, Dr. Ahmed, if you have a patient 480 micron and he's -1, and he wants to correct this -1. So you respect the residual stromal thickness, you respect the PTA, you respect everything. Would you go for 480 initial pachymetry? Everything is fine, everything is normal?
Yes, my cutoff limit is 460.
460?
460. My cutoff
LASIK or
PRK?
PRK.
Okay, for PRK, of course. No. Probably not. No, not that 500, not like this.
Let me just add us. I know we're going this way.
No return.
I'm sorry about that.
45 minutes.
Okay. Okay. Last week, I had a patient. She was 25 years old. She had a myopia of -1.75 in both eyes. I tried as much as possible to find anything wrong in her cornea. She is a pristine cornea. I sent her to do Corvus. Her Corvus is very good. The TBI, the CBI is very good.
What was the initial pachymetry, sorry?
520.
520.
Okay, yes. The only thing is that her father, I did one eye intracorneal rings and the other eye penetrating keratoplasty for keratoconus 15 years ago. I tried as hard as I can to find anything wrong with her, and there was nothing wrong. I did her PRK. 520.
Mustafa, if you are facing,
you have to do PRK.
Okay. Dr. Mustafa, if you are facing a case like this, if you have a look on this pentacam, and Dr. Karounis too, because we'll discuss this case with you, it's almost 480, the pachymetry. It has a -1.5 astigmatism. everything appears normal. Posterior elevations, anterior elevation, the pachymetric values. When you do refractive surgery for this patient,
Just show us the other eye.
it's the same, exactly the same.
Exactly the same.
Yeah.
Correction.
Minus 1.5 astigmatism, corrected to 1.2 or 66 or 2020.
The biomechanics.
Biomechanics, okay, is a good option. Okay.
Yeah, I would do femtolasing for.
لا لا 470 يا باشا 480
480.
480
Yeah.
التكنس.
For 80, I'll go for PRK.
Yeah, okay. Dr. Karonis, would you accept the PRK in astigmatism in this case?
Can I go back one step and ask to the list of the ingredients before going to the areas of topography,
Yes.
age,
Mhm.
and
Yeah.
history?
Yeah.
Because I think that a 40 years old
She's-
patient is totally different from a 20 years old
She's
patient.
22 years old.
All right?
Uh-huh.
In history, we know that there is nothing. right?
Nothing significant. No family history, no rubbing, no anything.
All right, so if all parameters are okay, this case is suitable for lamellar surgery as well. I mean, I would not be concerned with doing LASIK as well.
So you can do LASIK for this case.
Yes, because the PDA would still be more than
We're
acceptable.
talking here about femtolasik, of course,
Yes.
because here it's, yeah, I know, and because there are a lot of people here are still doing microkeratosis LASIK. When you,
All right.
when Karonis says LASIK, it means
Femto.
Yes, femtolasik. Let me say this also.
He doesn't have a microkeratosis.
I think it's useful to know that I had, as everybody, cases with, ectasia, and we know that besides all the, clinical features, parameters, diagnostic tools, and all of that, that really improved our diagnosis. The femto-LASIK, the use of a femto reduced the risk of ectasia by many times. So I think that femto-LASIK is the standard of doing it. But I would not be concerned with femto-LASIK in this case. I mean, if all parameters are fine, the thickness as itself would not be a driving factor.
So we have 3 PRKs, 1 femtolasik, no touch
For this patient?
for this patient.
Great. Now, thank you. In North Africa, in Morocco, when I discuss these issues with them, definitely they say we are different because their corneas are thin. So even their cutoff values for the PRK is 450, not 470. And they do LASIK below 500 because their corneas are thin. So geographical distribution population should be considered as well. But for me, no.
No, but if you have this is a bad D of this patient, it's normal, and if you have corvus for this patient, it's perfect. Would you change your mind after seeing this corvus, or you're still having the 400, the 500 micron limit for you?
No, I may go below, yes, I agree. For example, if the patient is 490, okay, and -1, -2, I can go, since the biomechanics are good, I can go for femtolasik.
Femtolasik.
Femto.
So the moral of the story is that Dr. Mazen specifically changed his whole mind after knowing that the biomechanics is perfect.
Yes.
And this patient, by the way, was referred from a lot of surgeons who refrained to do any sort of refractive surgery, even PRK, because of the thin cornea. But I did her a PRK, this is what I did actually, after doing a corvus, and I'm happy knowing that the biomechanics is good. So the biomechanics is the new player right now. It's not just the residual stromal thickness, the PTA, you have something that reassure you that you can go for surgery, and at least for medical legal, So if anything happens, you have a document that's okay. Let us accelerate the thing, very thin cornea. It's 4:30. Okay.
Again, age, amount of correction.
He's 30, almost 30. He's a male patient. The amount of correction is -2 sphere, -1 cylinder, correcting to 6 or 20/20. This is the beta count for the patient.
Can we see the profile,
Slope.
thickness profile?
Progression in the curves, yes.
But we all know that the progression curve would be different because it's outside of the limit, because the limit of the profile or the whole regression analysis that done in Ventacam, it was from 450 and below, so it's outside of the profile, so
Yeah,
it will
no.
exhibit a different curve.
Yeah, I look at the shape,
Yeah, I know.
at the location, the
Yeah.
shape, whether
Yeah.
it is consistent with the flat dotted or not. But it is high average. Many indices are abnormal. So for me, I don't.
Okay. Would you do cross-linking for this case? Do you consider this case a keratoconus?
No, it's just a thin cornea.
It's just a thin cornea. So we have an entity called very thin cornea, which is normal, and you don't have to do any sort of cross-linking or rings or whatever. This is not a keratoconus. It doesn't mean it is a thin cornea. It doesn't mean this is a keratoconus. But would you do refractive surgery for her?
Sure, phakic iris. A phakic iris.
Phakic iris,
Yeah.
but you don't touch the cornea.
No, I will not touch the cornea, I would implant a phakic iris.
And please keep patient under follow-up.
Of course,
Yes,
on
you
follow
have
here.
to do the pentacam.
Yeah, for sure, for
How
sure.
about PRK extra for this?
No, no.
Let this be at the end of the, because I have,
Which is
Okay, okay. Extra.
actually I don't have a timer by the way, so I might end up at the midnight or the gala. So I don't have a timer, so it's your responsibility. Okay. Hyperopia.
دكتور طارق بس الحلقه اللي فاتت دي هو المشكله هي الفين كورنيا ولا المشكله في البايوميكانكس بتاعتها؟
There is no biomechanical study for this case. I don't have the biomechanical study for this
لو
case.
كويسه حضرتك برضه not touching.
I will not touch because this is an extreme case. This is my record, by the way. This is the record.
I have a case similar like this.
Yeah, I know.
But I
Everyone
did-
has
I
a
did-
case like
I
this.
did for it film to smile.
No, no,
Then
no.
film to smile?
Yes, yes, yes. And around 7 years, the patient is still stable.
Lucky you.
Yes.
Okay.
Please
Lucky you. Lucky you.
don't do it again.
Okay.
Femtosmal is not an excuse to do thin corneas.
But
Femtosmal is a
I have a
I
comment.
tell my experience. Okay.
I know, but I'm experienced in the femtosmile more than 15 years now. Again, femtosmile is a refractive surgery that we should respect every aspect as refractive surgery. I don't do femtosmile below 460, 470, 430 is no touch. Please, you are very lucky.
Ectasia is a multifactorial process. So if we do refractive surgery for this case, we are just increasing the risk of ectasia. Might be 20%, 30%, but the patient may be lucky, maybe in the 70% of will not develop ectasia. I remember there is a paper in GCRS was talking about doing refractive surgery for thin cornea and follow up for long years and nobody exhibit any sort of ectasia, but this is not the rule actually. Okay, hyperopia. A flat cornea, if you have a hyperopic patient, you're happy that you're having a flat cornea because what you are intending to do is steepening the central cornea to correct the hyperopia. So if the initial cornea is flat like this one, it's 39.5, 40. So how much diopters of hyperopia can you correct for such a case? I know there are some rules in some countries that restrict for 4 diopters in Germany and stuff like this. But if the patient is asking to correct 6 diopters of hyperopia in this case, and it's flat, we know that each diopter of hyperopia is converted to 1.2 diopter on the pentacam, which means that the 6 might be 47, something like this, which is accepted prolate cornea after the operation. How many diopters were you correct, Dr. Mazen?
Great. I consider the KM, as you said, but as well, I don't go more than +4.
+4.
Why? Because usually the optical zone is 7 millimeter.
Okay.
But you will not get 7 millimeter optical zone after the operation. After 3 months, if you capture the patient, you will find it about 6 or even below because of the shrinkage, because of blah, blah, blah. The higher the number that you treat, the smaller the efficient optical zone that, yes, exactly, that you will get. So we are creating, if we go above +4, we are creating something similar to keratoconus.
Yeah.
Of course, the patient will be very happy if they are in the presbyopia age because we are creating
Negative
a
spherical
spherical aberration. But at the same time, they will suffer a lot during night and driving and so on. So above +4, I don't go, regardless of the KM, if it is still within the normal range.
For Hosni, this patient has a relatively narrow pupil, it's 3 millimeter. Would this encourage you to correct more than 4 diopters?
I've started doing LASIK for hypermetropia in 1997 because this was my PhD thesis. We compared LASIK and whole myectomy, keratoplasty, and hexagonal keratotomy. 3 arms of the same study in correction of hypermetropia. And I've been doing hypermetropic refractive surgery ever since. And my advice to everyone, do not go above +4. Never.
+4 is a golden number.
Yes.
Irrespective of the initial status of the cornea, how
Irrespective,
flat is the cornea?
the thing is, we actually we aim at centering our ablation around the visual axis, which we cannot do. So we measure the chord mu, and we try as much as possible to do things much nearer to the vertex of the cornea, hoping that this is very near to the visual axis, not the center of the pupil. And then these patients will end up with a keratoconic-like so they will. This is a very, very hard, a very large or a very strong stimulus for dryness. So these patients they always have at the tip of the cornea very dry, and the film is not stable. And you have a bunch of reasons to avoid doing a ginormous donut-shaped ablation on the cornea. So I think that the safety limit is +4. And up to this very moment, I'm not very happy doing a +4. I do the +4 and keep my fingers crossed. So I will never go beyond +4 in a corneal ablation.
Dr. Ahmad, you're having a good femtolasic machine that allows you to have a wide flap like 9.3 diameter, and you have a good LASIK machine that allows you to have a wide optical zone, and you have a customization that leads to proper centration of your profile. And as you can see that the angle kappa is not that huge in this case. Would you correct more than 4 diopters?
No, never ever more than 4 till now. And still telling the patient that the order ablations are definitely worse than the myopic ablations, and definitely the quality of vision will be not as you expect. It's very important point, especially for type A personalities who are highly demanding. They want to drive at night with a +4. Definitely, as Muhammad said, you are inducing steepening and as if you are doing keratoconus. So please, not more than +4 up till now. Nobody knows what will happen next.
Dr. Busra, do you agree with the number of the +4?
Well, I used to do hypermetropes, and the largest I did years ago, wife of my friend, and this was +6. At that time, the machine couldn't put in the machine the whole refraction, so you have to do it in 2 sessions. So this lady, she is now like
They're still married?
52, I guess. But she was happy actually, because she was, when I did it, she was like 35, and she had a regression, of course, of +2, but she could see in the morning, and getting in the presbyopia age, she wore glasses. The thing that she took my advice, and she wanted to do a blepharoplasty, so I referred to Dr. Aranya, and she wasn't happy at all. So the problem wasn't in the refractive, but
okay, that's good.
this one thing. The other thing that I did +2 and +3 and +1.5, and in different ages. Actually, also even in like 45, they do have regression. So again, after 1 year or 2 years, they will again need glasses for this. So for me, actually, my consistent now is I don't do a pro, because the patient will always go. Yes, this is my conclusion now. I don't try even to have hypermetropes, because somebody else will take the burden of discussing with the patient the recurrence, even the suing of having bad quality of vision, especially if they are in vision. So doing the hypermetropes, I wait for them until they get like 42, 45, and then we do